Dear colleagues, good afternoon, good evening, good morning to our dear colleague from the United States, to Leslie. Welcome to our webinar on human resources management during COVID-19, which we identified as one of the big challenges during the series of webinars that No Fear Project is conducting on the lessons identified during this pandemic. I would just start with the idea that we are not using the term lessons learned because in our profession in disaster management, we normally refer to lessons learned as something that you identified and you managed to do something about it, to change it for the good or to retain it if it's a good thing. And since we are not at the stage that we can demonstrate that we learned, we are using the term identified because this is the stage we are at where we can identify issues. As all of you should already know, but I will repeat it, we are talking about No Fear Project, which is a European Union funded project under Horizon 2020, with the idea that we have a pan-European challenge dealing with a highly fragmented sector, the acute healthcare sector, between private, public providers, research, academia. And if you just look into how many different types of ambulance service providers you have, fire services, third services, which means that are not a fire, neither health, services that belong to the hospital, charities, volunteer organizations, municipal services. And if you look into the variety of players in the hospital arena, you'll understand how fragmented we are and how difficult it is to bring everyone together, to pick the brains of everyone and try and make some sense out of what is going on out there. We, as a project, are organized around 3 pillars. One is work package 3, which is about the medical part, as we call it, or the actual treatment of the patient. Work package, and our colleagues from Policlinico Gemelli in Rome are leading this project, this part of the project, this work package. Our colleagues from CRIMEDIM, who are also the coordinators of the project, are leading work package 5 on training and learning, and Magen David Adom. My name is Chaim Rafalowski. I'm the disaster management coordinator of Magen David Adom. We are leading work package 4, who is dealing with the operations part, which means how we organize our response, how we prepare for that, and how we execute a response. Since February this year, the whole project and mainly work package 4 has taken a major shift from doing other aspects of acute incidents or critical incidents, focusing on COVID-19, how organizations both at the pre-hospital and in the intra-hospital are organizing themselves and what are the lessons identified from that. I can tell you that colleagues are teasing me that with the more than 500 lessons identified that we already have, we can do like 10 PhDs just on the work that work package 4 has done. For me, it is a source of great pride because we are managing to bring together, I would say, a common understanding and learning. And the most important thing is sharing. Israel was lucky to be 5 weeks behind Italy with the first wave of COVID-19. So we managed to learn a tremendous amount of small issues, but extremely important issues from Italy, both on the clinical side, but also on the organizational side, things that helped us do our response better. And we are trying to keep this legacy sharing with others so they can do better. I believe that COVID is not about rocket science. The vaccines will be a rocket science, but we are dealing about small practical things that by learning one from the other, we are doing better. And I believe that it is our moral obligation and professional obligation. We believe in Work Package 4 and in No Fear Project, that it is our moral and professional duty to share these learnings with others. So thank you very, very much to all our speakers today who will share. And just some, the idea, as I said, is to share, to learn globally, and to be better. The webinar is going to be recorded. We are going after the event to share the presentations and the recording on the platform and the channels of the project. So if any speaker does not want his or her share to be published and made available publicly, please let us know. The most important thing is please keep in mind that whatever is said during this webinar is the personal perception and understanding of the speaker. We don't have the time, to be honest. All of us are extremely busy. No one at the moment has the time to go through a due diligence procedure inside her or his own organization to validate our comments, so they are an official position of the organization. So don't look at any one of us speaking today as representing the organization. We are representing our own learnings and ideas. And so far, this has been an extremely fruitful exercise. Again, with the caveat that we must keep in mind that it is not scientifically validated research, a peer-reviewed research, or something that even went through an official approval by our own organizations. We have an extremely interesting and high-level list of speakers today. We would start with Ms. Leslee Stein-Spencer from the United States, from the Chicago Fire Department. She will present herself. Then we will go to Professor Barbara Yuen and Dr. Alexander Kreh from the University of Innsbruck, to Ms. Paloma Miravet from SAMUR, Protección Civil Madrid, Ms. Tess O'Donovan, I hope I pronounced it correctly, from the Irish Health Services, Dr. Rama Zilber, the Director of Nursing Research in the Nursing Division of the Israeli Ministry of Health, Professor Franceso Della Corte, who happens to be our beloved coordinator. Besides that, he is the chair of the ICU and Emergency Critical Care at the Maggiore Hospital School of Medicine in Novara in Italy, Dr. Safi Powells from Brussels, Ms. Madalina Duskic from the Ministry of Health in Romania, and we will end with Murvin Chan, the Head of National Disaster Management in the Netherlands Red Cross, with a very unique perception of a volunteer organization response during COVID. Without further ado, I would just go directly to the presentations. As you can see, we have a full house. I would kindly ask our speakers to stick to their 10 minutes so we finish on time. Thank you very much. Leslie, please, the floor is yours.
Good morning from Chicago, and good afternoon to you, all of you. As I go on and thinking of some of the topics, I kind of reflected on where we were and where we've been. We've all experienced many disasters, many situations. We developed action reports, and I can tell you none of us have put them to use. They're kind of like sitting on a shelf. And this pandemic, although we thought we were prepared, this has caused many challenges for us that we have never experienced. So we are kind of in the crossroads of how we are moving forward on this challenge. I'm Senior EMS Advisor for Illinois Department of Public Health and Program Manager for the National Association of State EMS Officials, and I'm going to limit my comments to the national level and not Illinois. Next slide, please. Since we don't have as many strengths as we have challenges, I thought I'd start off with the strengths. Many of us have implemented this mobile integrated healthcare program across the United States. This has helped streamline some of the numbers of EMS transports to hospitals. Many of these programs are able to treat and release at home. They have kind of tweaked their programs to deal with COVID and hopefully trying to keep some of the minor ailments at home and convince them that that's the way to go. Another strength is the multidisciplinary work group we've had at the national level. The National Highway Traffic Safety Agency Division of EMS put together a multidisciplinary group of EMS stakeholders. So included the fire chiefs, firefighters, EMS, and together We met twice a week working on national standards and policy issue papers that we could send to all the states to hopefully help them deal with some of this pandemic and the magnitude that we're dealing with. Some of them included crisis standard of care for EMS, how to deal with EMS licensure issues, EMS and call takers 911, and law enforcement and PPE issues. The next strength, I call this a strength and a weakness, is behavioral health. I don't think we initially realized the toll it was going to take on our first responder personnel. We went probably 4 or 5 months before we dealt with this at all. And then subsequently, we did develop a couple webinars, and we did them both nationally, and some of the states hosted them themselves. I will tell you, in Illinois, we developed a webinar, and we only had one. And we had in the chat box some critical comments of people experiencing some really sad issues and not having any resources to deal with it. The weakness of this is, one, is that we didn't deal with this right away, but two, we don't have enough resources to provide for all the areas that we are going to see. Plus, I don't think we've just tipped the iceberg on seeing what's going to happen with our mental health issues. What Chicago Fire did was they developed a brochure and they sent it out to the entire fire department for supervisors and partners to look at signs or potential areas that might be causing someone to be dealing with a mental health crisis and offer referrals. And finally, the other strength is our provisional EMS licenses. We were able to come to terms with the National Registry and many of our state EMS offices to issue provisional licenses for those who couldn't finish class, who didn't have a chance to do clinical areas by using simulation labs and other type of simulation procedures. The weakness of this is we put out a lot of EMS folks that have never touched a patient before and had never been in a situation, and put them by themselves experiencing this. So this is, I think we'll have mental health issues later on. Next slide. I just kind of look at EMS transport, all the options that we have now that we were dealing with and we changed due to the pandemic. Initially, most of the pre-hospital 911 calls went from, or call takers from the home to the hospital. Now we have opened up and made it available to go to urgent care centers, field triage hospitals, other referral facilities in order to hopefully offset some of the numbers going to hospitals. And next slide. And this is just kind of where we're seeing nationally, where we're seeing some of the most cases for COVID in the United States that we're seeing some of our overwhelming causes. Now, I will say, as we started to open up restaurants and stores, we started seeing more of that also because people were going without masks. Many of our states have gone back to shutting down and only doing outside dining. But like, for instance, in Illinois, we had 20 degrees today. We are not going to be doing outside dining. I could tell you that even with tents, there's only so much a heater can do. So this is really critically hurting some of our places. I could tell you in Illinois, we are going to see probably about a $6.2 billion budget deficit after this COVID response. Next slide. Challenges and issues. I will tell you, this is really, we don't have any good answers. Let me also preface by saying that. Treat and transport. While we're encouraging our EMS providers to treat at home and then, and not transport, what we're seeing is then they're not reimbursed. So are we hurting them by offsetting the number of transports to hospitals because they cannot get reimbursement? We have tried to look at this with Medicare and Medicaid, but without success. So this continues to be an issue on how to funnel some type of reimbursement if they don't transport a patient. EMS transports, we're seeing a significant increase of transports. Now this summer, not only were we dealing with increase of COVID response, but we were also dealing with civil unrest. So we had, our trauma centers were getting overwhelmed just with the numbers, or even trying to get into an area and see the civil unrest was causing, again, mental health issues for our providers and increasing our EMS calls. A challenge is to come up with alternate staffing patterns. Most of our ambulances for ALS are staffed either with 2 paramedics or 1 paramedic and 1 EMT. Well, as we're seeing, and as people get sick, including our responders, how do we come up with an alternate standard staffing pattern and yet assure that our patients are getting the best care? When you have 1 paramedic on a call with 1 other person that has maybe trained in CPR, what happens if there's a cardiac arrest or a significant trauma? Leaving that paramedic alone to function with just ancillary help is not the best way to go. Our volunteer EMS providers. Many of our volunteer services are now closing. And that's due to that those people in the volunteer areas in our rural areas, their full-time employers are saying, I don't want you volunteering on an ambulance because then you're going to get COVID and bring it back to our office. So we are having problems with our volunteer issues, including that we're also seeing many of the providers saying to our EMS folks, you can't work a second job because we don't want to take a chance of you getting sick. And then it comes under us for workers' compensation. Another challenge we're dealing with is public versus private EMS providers, especially as it relates to PPE. We have most of our public providers transport to an emergency department and they get a replacement supplies, where our privates are going from long-term care home to in-hospital patients floors, and they are not exchanging PPE. So where are they to get that? And then some of our hospitals say, well, if you're a private provider, you're making money. I'm not going, you can buy your own PPE. I don't want to reimburse for that. Long-term care facilities and EMS transport. Long-term care facilities have rules in place that say before anyone now can come into their facility, you must have a COVID test. That is each day, and you have to show proof. So they're now stopping EMS providers from coming into the long-term care facility unless they could show proof that they just had the COVID test. Well, who's going to pay for that? And it is multiple providers, multiple ambulance crews from the same provider that have to be tested daily. Now we're also looking at using paramedics in alternative settings. Hospitals that are so short nurses and doctors want to use EMS paramedics in the hospital. We just don't have enough EMS personnel to go around. Our prisons and our correctional facilities, we're seeing outbreaks in those facilities. And where do we go? Because they have to go with a guard. And hospitals don't want to overwhelm their area with the prison system and providers. So some of them have tried to set up maybe alternative care sites at the prison facilities, but it's again trying to find doctors and nurses to treat the patients. EMS resiliency. How do we recruit EMS folks into the field and keep them from leaving? We saw even in our mental health webinars that EMS folks saying they're leaving the facility. It is not worth it to go home and maybe bring this home to their people or seeing what they're dealing with. And we're not seeing, our classrooms are not as full as they used to be. So this really is going to be a problem for the future. And my final challenge, I think, is our PR campaign, or should I say their lack of. The public relations campaign, we didn't see, and we've asked that the media come out and say, you know, if you're not sick or if you have minor illnesses, stay at home. Call your facility, your healthcare, do a video conferencing or telemedicine. But instead they're not. So EMS is getting called for minor complaints and then they're expected to transport these patients. So I think our PR campaign is limited at best. Including now as we go along with vaccines and vaccinations is going to be our next final challenge, is how to vaccinate EMS. And I will tell you one of our problems for 1A is EMS is, they are the first group to get vaccinated, but you have fire departments that have fire companies that they also go on EMS calls. They might not have direct patient care, but they go on EMS calls. And now we're saying, well, you can't be in the 1A, you have to be in 1B. Well, that is going to be a difficult process to follow through on if the EMS ambulance is at the same firehouse and they're going to get vaccinated and the others don't. So these are our challenges. I'm limiting it to my 10 minutes. Sorry for talking fast, but I wanted to make sure I identified some of the many issues that we are dealing with. There are plenty more coming up that we deal with every day, but these are, I would think, some of the highlights. That's it for me.
Leslie, thank you so much for your marvelous contribution, as always. And I'm proud to say that we had an extremely interesting webinar with the colleagues from United States EMS on vaccination challenges for EMS. The summary of the webinar was distributed to all No Fear partners, and it is also available on the platform. So please have a look at it. I learned a lot, and there are many challenges associated with both the technical side of organizing the vaccination, but also with convincing our own people to get vaccinated and dealing with their concerns, issues that should be addressed before we start that. So I strongly encourage you to look into the document. So Leslie, thank you so much again. And I hand over to the colleagues from the University of Innsbruck, please.
Thank you, Chaim. Just to explain, we are at the same time at the University of Innsbruck as researchers and in the Austrian Red Cross, responsible for crisis intervention and for staff and volunteer support. And we are responsible in the Red Cross, but also in several hospitals for staff and volunteer support. So we will now talk from a psychosocial point of view. So we will just take this. Chaim, could you give me the next slide? So what we know is that, and many studies, also our own studies, have shown that healthcare workers in general are at risk of developing stress-related symptoms during pandemics, and especially during COVID. What we at the moment see is in Austria, we have the second wave now, hopefully not going into the third wave in January, but we will see. What we see is the difference between the first and second wave. What the special stressors in the first wave and also in the second, but in a different way, is working with PPE, high risk and fear of infecting the family members and friends, which in the EMS leads to, especially in the volunteers, leads to family telling them not to do their work anymore. Also in their jobs, they are told, as the speaker before has already said, they are not encouraged to do their volunteer work anymore because of fear of infection, a very high workload, new roles and responsibilities, especially also in the hospitals, where I have just given a course for leaders in the hospital, for leading nurses in different hospitals yesterday, and in several of the wards, hospital staff in the morning does not know where they will land, in which ward they will land during the day, because they have to do many shifts, because they have not enough staff at the moment. New roles, less informal social contacts in the teams, and moral distress. In the hospitals, it's mainly about how to deal with the dead bodies, how to deal with triage issues, and in the EMS, it's often about CPR and doing CPR in a fast manner, like for the first responders, and going into the protective care before starting it, and often they decide to just start it without their protective care. You can go to the next slide, and then we switch to Alexander. Alexander, are you here?
Yes, I'm here. Okay. Yeah. What we're doing at the moment at the university is we are scientifically going along with all these response measures that are happening at the moment. And what we're doing is, on one hand, doing interviews and focus group discussions with healthcare personnel in the course of the COVID-19 crisis. We started in March, doing the first interviews and doing it along the course of the pandemic with EMS staff, but also with staff in hospitals and in the care sector. And on the other hand, we're doing questionnaires, quantitative measures with healthcare and emergency staff. And we're doing that at 3 points in time. One, we started in July 2020, after the first lockdown in Austria. And the other one is happening right now in November and December. But it's almost closed. We ended with the data collection here, but have no data analyzed yet on the second wave. And in 2021, we want to search new data and then see how the perceptions of staff and volunteers over the time and their stress, perceived stress and traumatic stress and well-being throughout the course of the pandemic changes. Next slide, please. As I said in the interviews, we wanted to identify stresses and challenges, some of which you have already heard from Barbara. We will go a little bit more into detail on the next slide. And we collect best practice experiences from this time, from the first wave and also now the second wave, and identify resilience factors of what went well and what helped in staff and volunteer support. At the moment, we have 8 interviews from emergency medical services, 14 from hospitals, and 2 at the moment from elderly care. We want to progress on this, alongside with lots of experience exchange meetings and discussions that we had with experts in the last couple of months. Next slide, please. Barbara, I think you wanted to say something about the interview. Yes.
Okay. What we see is that moral distress and moral injury are important for healthcare workers, as I said already. No time for putting on the PPE when reanimation is necessary, or being confronted with wrong information from patients at home. What we often have is that also in the EMS service, that patients, they don't tell the personnel that they are COVID positive. And so there's what we see in general from the first to the second wave is in the first wave, personnel was highly motivated. There was a high solidarity. And they really wanted to help. At the moment, we see a lot of polarization in the population, but also in our teams, and a lot of frustration and demotivation, and a lot of anger towards the population, because they are not, they feel the population is endangering them and is not really taking them seriously anymore. And this enhances the moral distress, because people often have the feeling in their work they have to do things that are against their moral principles. What we also see is that leadership plays a very important role, especially organizational justice. For example, there's a big discussion and a big polarization in teams, because in Austria and in many other European countries, the decision makers have said that healthcare personnel gets a reward, a money reward for their work, and then in the second step, a discussion started who gets it and who doesn't get it. And then they said those who have worked with COVID patients, they get it, and the others don't get it. And so there was a split up of these two groups, and this is extremely destructive for the teams. The next one is the basic on-scene support. What we see is that healthcare personnel gets very angry if they only get a telephone number where they can call psychologists, and they don't see the psychologists or the mental health professionals in the field. What they need is they need a good framework. They need healthcare professionals, mental health professionals, peers and team leaders who go into the field and provide a good framework that helps them to do their work in a good way. Yes, you can give me the next slide, or give Alexander the next slide. Thank you.
Yes. So as I said, we're also doing the quantitative measures. And what we've done here is send it out to our European networks. However, in the English speaking questionnaire, we had quite little response. So what I'm presenting now is mainly representing the analysis of the German-speaking country sample. So it's mainly Austria and Germany and some parts of Switzerland and northern Italy. The main part, and what I want to present here, is the sample of the emergency medical services, of which we had 637 people filling out our questionnaire. And we collected stress, the well-being, resilience factors, and also some items on risk perception and general perception of COVID-19 and the situation, also of stressors connected to the tasks they have to carry out at work. Next slide, please. So that's the scales, the perceived stress scale, WHO5, IASR. If anyone wants to check what scales these exactly are, you can get in contact with us. Just for a quick overview, we have put them on this slide. Alongside, we had, as I said, general perceptions regarding the pandemic, for example, risk perception measures, and we oriented on the WHO survey tool here, which is quite well. What we can say is that in general, we have a quite resilient group in German-speaking responders in the EMS field. For example, if we look into the perception of risk, of own risk, of fear of infection, of a perceived threat, we see that it is perceived as a threat, but people feel like they can actively do something about it in our questionnaire, and that they felt quite well protected in the first wave. Next slide, please. But what we can identify from the data on our scales is that there are some risk factors and groups of staff and volunteers who have higher perceived stress and less well-being. What we see is that staff and leadership roles have higher sense of coherence and higher resilience than others. But younger staff, and especially the inexperienced one who are working in civil services or as trainees, have much higher, significantly higher traumatic stress and perceived stress and lower well-being during this time. Next slide, please. We also see, what we see in lots of stress questionnaires is that women seem to have higher stress levels than male staff, especially in that group of women who have lots of contact with COVID-19 patients, so they have a high exposure. They differ significantly from those who have not. We're looking at the moment into reasons why that is, and it can be that women are in also other roles, for example, working in the health sector, working in care jobs, working more part-time, having more responsibilities and roles also at home in family care during the time of lockdown, and so on. So it's probably some different reasons leading to this difference. Next slide, please. We also see, which is not much surprising, but something that we have to count as, of course, that staff that perceive themselves as especially vulnerable during regarding a COVID-19 infection, for example, due to other health issues before, have general higher traumatic stress levels and lower well-being than those who do not perceive themselves as vulnerable. And we also see a difference between those who are employed and those who are volunteering in the EMS services. So those who are employed and have to carry out the job and do not do this on a volunteer basis also are more stressed or have higher stress level than those who are volunteering. Next slide, please.
Alexander, 3 minutes.
Yes, we're coming to an end. What we're doing next is to compare the measurement from this first phase to the second one, and prepare the third measurement point at the moment. If you need more details or want to follow our research, please get in contact with us, and yes, we can get more in detail later. Next slide, please.
This is our last slide. So what we do at the moment is we focus very much on the leadership, coaching and training, where we have peer systems. They are very active, but they do mainly on-scene support. We do a very much training and coaching for psychologists and mental health professionals in order to make them understand the specific challenge that healthcare workers experience now during this pandemic, and that the classical psychological approach is not adequate here, and that healthcare personnel gets rather angry if you treat them as patients, or if you don't see them as a very resilient group who just needs a healthy framework, a healthy working environment at the moment. And this is why leadership is so important, because providing this healthy working environment is the main issue at the moment. Yeah, thank you.
Thank you very much, Sharon Alexander. I think extremely valuable. We, of course, would like to follow this up. I would just add that I think that if I may suggest something from the Israeli experience, one of the issues that we saw is the issue of networks of support.
Yes.
That we saw that there were two groups that had more issues. These are the very young EMTs and paramedics who live alone and had the issues with the very simple things. There is a lockdown, I don't have time to go to the supermarket and things like that. Mm-hmm. And those who have little children and both parents work at the healthcare system, so they are essentially at the workplace, and there were no schools and kindergartens, and one of the major stressors was, okay, what do we do with our kids? And our parents are elderly, so we're afraid to bring the kids to them, and things like that. That is something that required, I would say, an institutional response to those issues.
Thank you, Chaim. Very important. Thanks.
Thank you. We will keep on this conversation for sure. Thank you, Barbara. And you will receive the presentation. You will receive the presentation with all the references. So we are going immediately to Señora Paloma Miravet. Adelante, por favor.
Thank you, Chaim. I was trying to turn on the video, but it says me I have to restart Zoom, so I'm not going to take that risk in this moment. So hello, everyone, and we are going to talk about what we have done in SAMUR. Next, please. And how we are now. As you see, we are in the second wave, trying to finish it and wait for the beginning of January to the next one, I'm afraid. But we are getting better. Our numbers were worse in the second wave, but the severity was worse in the first wave. Now we are getting better, and especially in Madrid, so we are happy about that until Christmas time. Next one, please. And talking about the extraordinary measures we took in SAMUR regarding to the operative staff, the ordinary operative staff, our priority was to protect the human capital. Almost all the healthcare providers asked to work overtime because they wanted to help, because they wanted to be there, because they wanted to participate. But in SAMUR, they made a strategic reserve of the operative, so they could bring elasticity if it was needed and when it was needed. So they made no extra shifts. Mention of a shortage of the personnel, no days off, no holidays, and everyone in their shifts and as normal. Next one, please. But what we did was increase workloads of support services like maintenance of vehicles, maintenance of electromedical devices, the psychologist on duty, because the psychologist not only was now attending the injured people, but also our staff when needed. The physicians providing non-emergency care, the logistics, and chief physician, nurse, supervisor on duty to coordinate the different works we were doing, different and new for us works we were doing, like in IFEMA, secondary transport to hospitals, and COVID bus, and many other things. And we increased workload, of course, in disinfection teams for the ambulances. Next one, please. We overload the physician attending not emergency cases, so we could increase the availability of the advanced life support units. These were taking care of patients who didn't have to go to the hospital, so they could attend it in a car with some material, like arrested people, psychiatric patients, and so on. And the electromedical equipment, they weren't working. They are not working 27 hours like I see there, 24 hours, 7 days now, and they took care of keeping the material, replace it, and have it in order to be used when necessary. Next, please. And this is very important, and it has been, I think, a very important thing. We did have 2 CBRN teams on duty. We usually had only one with 1 person, but we have 2 CBRN teams, one at the same with 2 persons, 2 specialists, CBRN specialists, 2 helping to dress, answering doubts, helping to manage the material, indicating what kind of level protection did they have to wear. So our staff was ready to attend the people. We had another CBRN team with 2 persons at SAMUR headquarters to designate
Got some training from us.
persons attending a suspected or uninfected patient, and they did indicate step by step how to proceed, and they make sure they didn't make any mistake when undressing. And we did have a third team. This is a team, they usually go, previous please, that usually go in the basic life support. They got 2 EMTs, but they do have a CBRN profile. So in case we need more people CBRN profile, they could go wherever they were needed. And this was very important. Next, please. This is the SAMUR data of the infected people during this period. The normal sick leave is approximate 8%, 9%. We can see in March we did have a 6% more, in April 8% more, in May 5% more, and in June again 2%. So it was like more normal. Anyway, this was much better than the media in Spain. So we are happy about that. Next one, please. The difference between the first wave and the second wave, in the first wave, we did have 98 positives with PCR test or antigen, and more in physicians, I think, because of the management of the airway. And at the beginning, we weren't so protected as we had to be. And very important, 9 asymptomatic positive between our staff, diagnosed by our PCR. Every one of the staff was taken a PCR. So we detected these 9 asymptomatic. As you see down, the different weeks of March and April, the worst part was at the beginning, at the middle of March, with the more number of PCRs positive. The second wave from July to September are these data. The principal contact was a familiar contact, not working contacts. And the positive cases were 6 at the household and only one at work. So it looks like we were doing the things better at work. Next one. And in conclusion, we think that saving efforts to the ordinary operative has been a good idea, because this is being very long, and people is doing well, because I think we didn't overload them in their everyday job. The increase of the workloads of the support teams brought us a better organization, more security, and low number of infected workers. And in this second wave, we don't have extra shifts except from the CBRN teams. They are still making extra shifts. Electromedicine has stayed 24 hours and disinfection 24 hours, the same. And the daily briefing we were doing at the beginning of every shift is still doing. We see more infected at the household, very few infected at work. And that makes us think that the previous measures, along with the training and the supervision, has shown to be effective in this case. And thank you very much. That's all we can say from SAMUR.
Paloma, thank you so much. First of all, I don't understand why you can work 27 hours a day and the team cannot.
We are SAMUR, Jaime. We do everything.
Yeah, and I think that the key issue is that we also see that most of our positive cases within Magen David Adom are coming from family and social contacts.
Yeah.
So for me, the interesting question is how we manage to convince our people that are so cautious while they are on the job and take so much of their time and energy to be well protected, how we convince them to use some of that energy and knowledge while they're at home. I think that this is one of our greatest challenges.
That's the key, yeah. I agree with you.
Ms. Tess O'Donovan, please, the Irish experience.
Sound on? Yeah. Good afternoon and good morning and good evening to the people that are on the call. So it's my great pleasure to be invited. So I suppose my area is operational in acute hospitals, but it very much reflects the previous speakers. So we'll start and roll through the first 3 slides there, if you don't mind, Kyle. So this just shows where we are. We're in the south of Ireland, the geographical area, just a neat line across the country. And if we go to the next slide, we just have a very nice picture of our hospitals taken by night. We have, in our population, there's 900,000 people across the counties of Cork, Kerry, Waterford, and a super regional catchment of 1.2 million. And we employ nearly 12,000 staff across our hospitals. Our hospitals range from larger acute tertiary referrals to smaller medical assessment type units. So there's a lot of range across our 10 hospitals. So next slide, please. I mean, I think we can all say the impact of COVID has completely taken us by surprise. It has changed all our parameters, and it has certainly challenged our existing way of working, how we've delivered it. And really the most key thing is that we need to, from the HR perspective, have more in-depth thinking of how we're going to deliver services into the future. So next slide. Some of it I've already covered. I think probably of most interest there is our OPD attendances. If you look at that, 500,000, our ED attendances, 230,000, and local injury unit, they were significantly impacted in terms of COVID. So if I go to the next slide, I suppose our timelines, there's always a geographical issue. Dublin think it's the capital of Ireland, but we all know here in Cork, Cork is the real capital. If any of you have been to Ireland and have been to Cork in particular, you understand that. So I suppose we had our first case in Cork University Hospital here in the city in Cork on March the 3rd. And I know you would say that really at that stage, that's where the distance between Wuhan and Cork narrowed considerably. And for us, because we were in the eye of the storm, but we're coming in after the Italian and Spanish experience, we had some learning already under our belt. But when you hit the first case, no matter if you're the biggest hospital or the smallest hospital, it is significant for everybody involved. March the 29th in Ireland, we had our first national lockdown, and October the 21st, our second. Huge differences between the experiences from the hospital side. First national lockdown, everything stopped. OPDs, clinics, schedules, scopings, everything ceased. Second lockdown, we kept services going. And I think that's significant in terms of the patient pathways, the prep work that had to be done, the additional workloads and work streams that had to be put in. And that's a huge difference from the HR perspective when you're looking at how you're managing issues between you know, a pandemic with different streams and different waves coming at you. We had a 30% drop in our KPIs in our cancer system example, you know, the rapid access clinics. So we knew the second time around, you could not stop everything. We had to keep services going. Next slide, please. Can you roll? Yeah, thank you. I suppose one of the key things for us was looking at the advice that was coming from the WHO. It was around getting together, getting communications going. Our media was quite strong. We were having daily reports. I mean, our head of public health nationally is I think known in every single house across Ireland. It's Tony. What does Tony say? So our advice and our guidance nationally was very strong. We still have daily updates on our news programs, the highlight being what are the COVID numbers today, how many cases, how many deaths. So it is in public discourse in your face every single day. What we did here then in terms of our own group across the hospitals, we looked at it across all the different strands, public health, community, including the GPs, ourselves in the acute service and the ambulance. And really it was getting the right information out, where we were, where patients needed to go, where there were activity, where there was COVID outbreaks. So we ourselves in HR had our own weekly calls, and I then had daily contact with our hospitals and their HR people. And probably unique to this area, you had the interagency management group, where with the partners, our Cork local authorities, our police and defence forces, as well as the voluntary services, we were all in the contact and everybody supporting, because I think the hospitals in particular recognise you can't do this on your own. You have to reach out into the wider community. So we might go to the next slide. So I suppose when you're looking at the lockdown, and the very first time it happened above in CUH, I was in that weekend myself, because I think it goes back to the previous speaker and Barbara in particular saying staff, you know, are somewhat reassured by individuals being on the ground. I would have worked in that hospital, I would have worked in ED, so I would have known people anyway. So you're looking at how you do contact tracing for over 200 staff, because our first case had been in the hospital for quite a while. So you had a huge amount of, okay, how many people are we looking at? We had ITU staff became unavailable. We had 20 ITU nurses taken out, needed to be self-isolated in the first case. So that was huge to keep an intensive care unit going. And the big thing for myself and the HR with the occupational health physician was we would not allow any of those to come back outside of the 14-day guideline, because we wanted reassurance that the potential for cross-infection and the potential for the spread of COVID, we would have to resist as far as we could once someone was determined to close contact. And we had derogations nationally for essential services, but I think that was a strategic decision we took ourselves here in this area, and that served us well as things progressed. We were in full compliance with our national public health advice. We had specific health and safety guidelines that issued nationally. There's national protocols across all government departments, and particular ones then for ourselves for health. So for me, from the HR, it became about employing the employee well-being, staff sick, staff isolating, staff waiting for tests, the implications of and the employee well-being. So move on to the next slide. So I suppose the immediate response was deployment of staff to the critical functions. So you talked about staffing your intensive care unit, a particular issue in one hospital where a number of the ITU personnel were unavailable, your EDs and your areas where we had retained patients in-house. So for patients that remained in our hospitals, it was a very worrying time for them, because they were suddenly in an area they had no contact with their family, and they were on a journey, not with an identified date of discharge. So they had their worries, and we had staff managing that cohort, as well as staff that were saying, what's going to come in the door now? How do I manage what's coming in the door? So we were very careful in terms of the PPE, the patient pathways, your COVID and your non-COVID pathways, and staff being very clear how they were working and training and upskilling ongoing all the time. Because I suppose while we had initial cases, we didn't get to the level that the Dublin hospitals got. So we had time to invest in training, and we were lucky to have that. And again, our clinicians would have been in contact with their colleagues in Spain and Italy, seeing what was going on there, seeing what they could be doing in advance of particular issues happening for us. For me, occupational health falls under my remit. So it really was getting the systems up and running in occupational health to give effective contact tracing and to get staff swabbed. we realized very early on the asymptomatic cases were going to be a problem, because we couldn't figure out how come, you know, there was a certain amount of staff being positive and they hadn't been in contact with patients. So it became clear it was in the tea rooms. It was when they were sharing transport, maybe coming in and out of work at the beginning when we weren't so well organized. That's where the transmission was happening. So we put in our own staff testing service for our hospital here in the city in Cork. And we also then had swabbing on demand, which you would say is outside of the protocol, but which served us well. Then later on, as the COVID became more advanced in the first wave, there was requests for assistance in the community for residential care. Our older populations are in private and public care in the community, and their medical care is provided by GPs. You could have a number of GPs attending a unit. They didn't have the expertise, they didn't have the infection prevention control assistance. So they looked to us in the hospital for that kind of assistance, for microbiology, infection control in particular, but also as their staff cohort got wiped out, they looked for nursing, healthcare assistance. So it was then we needed the response to happen for the communities, because what happened in a few of the initial cases is some very sick elderly people had to be moved into our acute service. And some of those people actually would have been better served if we could have had a response in the community. And that's what's developed and has worked, which is a good outcome. I suppose from the HR perspective, the immediate focus was health and safety of employees. And that was something that was lived real for every single employee that came into work every day and didn't know what they faced. And there was the background stuff then in terms of the office space, compliance with social distancing, simple things, mapping your floor, what way they're going, screens, hand sanitizer. So I suppose that then rolled into the second, made the second, I suppose, wave that bit easier to manage. We had established practice. We had people working from home. Go to the next slide. I suppose the critical issues for us is the resource in the critical service. I mean, at the time, it couldn't have happened at a worse time. In the Irish Health Service, we were very much in a control of recruitment and growth. So in March, at the time of the first COVID outbreak, I released every single post that I had in recruitment that had been delayed. So that was about 800 posts across 10 hospitals, which was phenomenal. So we had an incoming deficit in staffing before the COVID hit us. So then in terms of challenges in the workplace, working from home wouldn't be the norm, even for admin clerical staff. Safe choices then to return to the workplace or work from home. That was a lot of discussion with individual managers and staff. And to be fair, our frontline roles, you can't do them other than in the hospital setting. So a significant number of our people were going to have to be in the working environment. So it was making sure the working environment was fit for purpose in terms of COVID demands. Our ICT structure and infrastructure is something we've struggled with, and it is something that's improving. We've had huge supports then put in place in terms of vulnerable workers. We have people that, you know, have a health concern and can't work in the workplace. So they were really concerned around the impact of coming into work. You had the employees then that had the care needs, and I think it goes to some of the points the earlier speakers were making as well. How do I manage my family? I have direct contact and calls with staff who, after their first night on duty, slept in their car because they did not want to go into their home or into their house for fear of transmission and the psychological stress in the workplace. It's very different now. Our cultural norms, no matter where we are now absent. The ability to reach out, comfort a colleague, hug a colleague, comfort a relative, that's now different, and that's creating a huge psychological stress. Next slide, please.
Tess, 3 minutes, please.
Yeah, perfect. So what we did do, and it's only just to I suppose ease some of the issues for staff, we arranged for temporary accommodation for staff who had a worry about staying in their own house if they had an elderly relative or they had childcare demands. So what we did in terms of our own structures here and across the country, we accommodated 334 people in accommodation for while they were working or while they were COVID positive that they needed accommodation. But we actually had our employee assistants, who are not psychologists but offer employee support, put in as part of that. So that supported staff. I would say if you were to ask them, they'd say it probably wasn't enough. It was the best we could do at that stage. Go to the next slide. I suppose how we've adapted what we've learned, I think the ability of frontline staff, and we've all said it, people can work. The breakdown of traditional barriers and an integrated approach is the one thing that we saw and continue to see. We had no inbuilt resilience, so the importance of having that and understaffing complicating matters. And then we didn't have enough in terms of occupational health psychology or health and safety. So they're the key things we need to look at from HR. Next slide, because I think I'm nearly there at this stage, am I? I mean, again, and as echoed earlier, strong leadership, collaborative decision-making. To some degree, if you step back and let the clinicians get on with it, they will. So our job from the HR was to enable them to work and to deliver the pathways of care, and to be flexible, to look at the changing practices and to support that. And for us, there's a huge digital shift in the work practice. So that's no harm either in terms of moving us into this century. Next slide. Strong communication and challenging to keep the information, I suppose. One of the things we challenged with was the NEFID, and our national guidance was international travel. No, you had to self-isolate on Friday. The following Monday, no, you could start to work. So it was just how quickly information was flowing and how you needed to have a process in place to keep people up to date. And the most significant thing I can say here today, critical to support managers to listen and also to hear the staff concerns. That could be about the availability of their family worries. That was the most essential piece of work I could do as a HR, that our managers were listening to, they were heard. And I think that's one more slide. I think, am I nearly done? Yeah, and I suppose we have an Irish proverb, or scrá céile, Irish Nagina. It really is people live in each other's shadows. It's the shelter of others that help us survive. And I think it's a nice phrase that sums up the experience that we've had here. Thank you very much.
Tess, thank you so much for a very enlightening presentation. I hear one very interesting comment from your side. It's about health safety. And I think that we all did a remarkable work when it comes to the areas where we treat our patients. I heard you speaking about doing the same where we work on the more administrative side of things, on our restroom, on our common rooms and things like that. And I think that this is something I believe we personally could have done much, much better, because we were concerned really about the interaction with patients who are possibly COVID patients, and we did not pay that much attention to our colleagues that also could be positive cases also. Yeah. So thank you so much. Dr. Rama Zilber from the Israeli Ministry of Health, please.
Hello, everyone, and thank you for the opportunity you have given us today to share with you some insight on managing the human resources in the days of Corona. So the nursing division, has been part of the national emergency system of the Israeli Ministry of Health, is in charge of managing the personnel in the health system during emergency periods. So, and I would like to share with you today some main issue we deal with during the COVID-19 epidemic. Next one, please. So the COVID-19 virus arrived in Israel in March 2020, a month in which Israel faced the first wave of the epidemic and a general lockdown declared for its residents. In May, the morbidity curve was flattened and the economy was fully operational, including the opening of the education system on the 1st of September. Unfortunately, in the half of September, there was a sharp increase in the number of the confirmed patients, and a decision was made to impose another lockdown that lasted until the half of October, when a gradual return to the routine began. But these days, we are witnessing a steady increase in the morbidity, and the coefficient of contagion R has crossed the 1. The next one, please. As you can see, the relief of restriction on trade and movement are accompanied by an upswing in the coefficient of contagion. The next one, please. So coping with the first wave of COVID-19 was characterized by great uncertainty, but during which teams gained knowledge and experience that was the basis for continuing to cope with the situation. Next one, please. As I mentioned before, the division, has been part of the national emergency system of the Israeli Ministry of Health, is in charge of managing the personnel in the health system during the emergency period. And as part of our activity in this field, we began collecting data about the health personnel who are absent from their jobs due to quarantine or COVID-19 sickness from the first epidemic in Israel. As the graph shows, the number of quarantine workers was high from the beginning of the epidemic. The growing number of missing employees is seen as a potential threat to the functional continuum in the health system. and the possibility of monitoring, make decisions based on this data seem like an advantage by the policymaker. The information from the Health Institute transmitted online to the data system on the Ministry of Health on a daily basis. And during the first wave, the activity of hospital and health institution was significantly reduced so that workers could be diverted from various places where operation declined or closed in favor of ward where there was a shortage. However, upon returning to routine activity, the flexibility in personnel has diminished and the absence of employee is a heavy burden on the system. Next one, please. The information of employees are targeted according to the type and name of the institution in which they work, the sector to which they belong, and the department in which they are embedded. Special reports sent to the director of the institution that receive information about the organization they run every day. Next one, please. Here we see in blue a graph of corona morbidity among the population in Israel from March to December, and above it in green, the graph of reflecting the number of personal members who fell ill in corona at the time. As you can see, the trends in both graphs are very similar. Next one, please. When we analyze morbidity data among personnel in general hospital, combined with regional morbidity data 1 week before, we found a positive correlation between regional morbidity and the number of verified staff at whole hospital. The understanding that regional mobility and an increase in staff mobility in hospital enable institutional administrators to stricter protection policy and take additional measures in the early stages of increased morbidity rates in the area where the hospital is located. Next one, please. So our main insight, the recognition in the importance of maintaining a routine alongside coping with the corona has been solidified in the light of the recognition about the consequence of the limitation arising from the epidemic on all areas of life, the economic harm and increase in the unemployment, the closure of the system and the harm to children and their family, lack of health promotion activity, and worsening situation of depression and violence. Second, during the corona days, recognition of the importance of human resources was sharpened again, and within it, the understanding that it's urgent to act to preserve its resilience and increase its competency according to the needs of the hour. One of the most significant actions was and still increasing the number of nurses with post-basic intensive care training. During the first wave, it was decided that corona patients would be treated in all hospitals throughout the country, thinking that the experience acquired by the teams in a whole hospital is important and would enable the cope in the future. Next one, please. The next one, please. So based on the main insights, the following processes were performed. 1, increasing the number of medical and paramedical jobs in the accordance with gaps in personal staffing and according to the level of mobility, monitoring the staffing process, and giving a quick response by change or adapt policy to the needs of the clinical situation by creating and publishing professional guidelines that will enable health workers to manage their job safely and efficiently. Continue monitoring daily snapshot of the absent personnel in the health system, and increasing the number of nurses in the postgraduate intensive care courses. And this year, additional courses will open beyond the original plan, and within a year, 100 of intensive care post-basic graduate nursing will be added, the intensive care and the medical wards. And strengthening resilience and reducing erosion according to the needs expressed by the employer. Next one, please. So the increasing of the medical job, including the following steps: mapping the number of healthcare personnel available to the health system in terms of quantity and quality in accordance with the reference scenario. The process was carried out by contacting all health organizations in the public and private system and requesting the data of the personnel employed by them. The mapping data was basis for both identifying gaps in healthcare personnel among the general hospital, determined by the number of COVID-19 beds that will be open in each hospital, the assessment of the personnel already available at the institute in relation to the standards set for each such bed. The hospital winter's preparation program included adding COVID-19 beds for each hospital and the addition of thousands of doctors, nurses, healthcare workers, and administrative jobs. Exposing sources for personnel reinforcement include private hospital and clinic, the community health system, medicine and nursing student, retired health professional, and volunteer. Recruiting, the recruitment of personnel required preparatory activity that included virtually placed employee in hospital wards and preparing a legal emergency infrastructure that would enable the shifting of personnel from the private institute and community to hospital if necessary. The allocation of staff was based on the information obtained from the government data source on employing individuals in Israel, which includes such a demographic detail. The placement of the individual work in a specific hospital was done in accordance with professional skill and place of residence data. In addition, the area of epidemiological investigation is reinforced by hundreds of employees trained to perform epidemiological investigation and to assist in the amputation of the chains of contagion. These employees included nursing and medical students, as well as airport authority employees who were shut down due to the lockdown. These relatively early reactions were based on the lesson of coping from the first wave and recognizing the importance of recruitment, allocation, and staffing for early vocational training and the acquiring of clinical experience in treatment of COVID patients. Next one, please.
Rama, 2 minutes, please.
Okay. As part of the nursing administration activity in the national program to strengthen resilience and reduce erosion among health workers, 2 hackathon meetings attended by more than 100 nursing directors from hospital and the community in order to discuss and raise ideas that will form a basis for formulating strategy to support the resilience of nursing staff. This event has come up with dozens of ideas that have finally been rated by participants according to the degree of the applicability and efficiency. The top ideas were distributed for ranking among nursing workers in hospital and the community, and more than 1,300 nurses complied and rated their proposal. The main area that employees rated as significant in strengthening resilience for them included concern for the physical well-being in the workplace, allowing financial support, accessing health services in the workplace, sharing knowledge and organizational information, and concern for the welfare of family members, including children and elderly, in which the workers support. The findings of the data processing are currently being discussed to continue the process, which will include formulating ways in which employee preference can be applied to action to support their personal and professional resilience. Next one, please. And if I don't have time, we can jump on this. So managing the human resources in the day of Corona is an invaluable and challenging area of responsibility. And alongside the increase in the number of jobs of medical teams, we see tremendous importance in maintaining safety and well-being of the worker in the health system while maintaining constant dialogue, listening to the leader, and providing a real response to their need. Thank you.
Thank you so much. I hear the need for a reserve unit of healthcare workers looking into additional personnel in times of urgent need, and I think that this is something that we will all have to work further as days pass by. Professor Franceso Della Corte, prego, signore.
Prego, signore. Thank you very much for using Italian. I know that you are working very many times in Italy, so I'm sure that your Italian is very good. So, good afternoon to everybody. I'm very pleased to participate to this session, and thank you, Haim, for having invited me. I will pick up one or two topics that we faced during this COVID pandemic in Italy. So please, could you go on the next slide? So Italy is still hit by the COVID pandemic. You see that we had about 60,000 people who died for that. And we still have 3,345 people in the intensive care. Next, please. So we noticed that probably for our interest in disaster medicine, during either the first and the second wave, we applied the most important principles of disaster medicine, such as the disaster cycle, the application of the command, control, and coordinations rules. We made triage, of course, and we implemented also the surge capacity. We did probably I hope the best for the most, and we changed our ethical principles because we thought that we had a real disasters during this. You know that Italy was the first European country that was beaten by the pandemic, and it was the first wave especially was very bad. And also an important point that I want to underscore is the specific education that should be needed to face this kind of disease. Next, please. I think that human resources are one of the most important pillar of surge capacity. Surge capacity is the ability to implement the response in terms of staff and systems. Next, please. An example of that, for example, is how we managed intensive care patients that came to our hospital. We usually have a general intensive care of 14 beds, and we faced the first and the second time the high influx of patients with COVID, implementing depleting the patients, moving the patients from this intensive care, that is the biggest intensive care in the region, to move all these patients in intensive care, in neurointensive care and cardio intensive care, and to start from 0 up to 26 patients that were intubated in the new area. Next slide, please. Next. Yes, filling a corridor that was just aside of the intensive care to implement the number of intensive care beds to 26 in total. This situation generated a big impact on the staff and all also the management of these intensive care patients. Next slide, please. And this was also the origin of a lot of problems on health personnel. You see, this is in function, and we had about 120 patients that were severely ill, and they were all intubated and ventilated. And you see, if we didn't have the possibility to expand our area, we probably were not able to face this kind of this kind of influx of patients. Next time. But this situation brought, even if we applied the principles of disaster medicine, we had a lot of troubles. The most important impact on the health personnel was that for all of them, or for most of them, it was the first experience in responding in a large scale public health emergency or to a disaster in general. And most of the healthcare workers did not study disaster medicine in their training. And the current pandemic should stimulate to consider introducing disaster medicine as a medical and nursing school programs. And at the moment, they don't have it. We don't have it. Next, please. So during our preparation, we needed an effective, specific education and training for the healthcare workers. And having not it before, we're starting to have a just-in-time training for all of that. And it was a huge work because most of them were not didn't practice any kinds of dunning and duffing, and so we started to the very first moment to make this kind of information, and knowing that personnel that is not used to work in such a condition could bring to a malpractice and to secondary infections that even now is extremely high. Next, please. So we started with this just-in-time training that was made either for nurses and also for doctors. You know, when we're talking about staff for 14 patients, and the day after we implemented the number of patients to 26, we had to educate either nurses and doctors. Next, please. And we started it, and I think that we made a good job in a very short time. And the first of all these things were to how to be done and how to be done in this kind of prevention of contacts. Next. And we started a project that was dedicated to nursing and doctors' education. And this is what we did. In a 3-day course, we succeeded, in a 1-day course, we succeeded to allow them to be well dressed and to prevent their contagious contact with the patients. Next. And the same we are doing now for physicians. You know, we doubled the number of people who participated to the activities in the intensive care and in sub-intensive care. And when we finished the internists, when we finished the critical care physicians, and we moved to the internists, and we moved to pneumologists, and after that, all of them were involved in the clinical practice. We started to gather other doctors that were absolutely not experienced in intensive care management, and so we started a just-in-time training for them. And you see, these are the topics, and these are the content domain and the specific contents that we used for a 3-day course to implement their competence and to help us during the daily management of the patient. Next, please. What does it lead the absence of a culture in disaster medicine and disaster management? We had a very high number of people who have been contagious, have been contacted by the virus, and they stayed home. You see that in the second wave, we raised up to 70,000 people, nurses and doctors, that were touched by the COVID virus, and you can imagine how this can limit the presence of doctors and nurses in the hospitals. This is the Italian data, and this demonstrates, in my view, that education and training to prevent the contagions is very clear. And most of the patients and nurses that were hit by the disease were working out of the hospital. In our hospital, in our staff, for example, we had only 2 doctors and nurses that became COVID positive, and this is due by the 2 different pathways inside the intensive care, the clear and the dirty pathways, and with the good use of PPE use. Next one, please. And he's also brought this bad view. The number of physicians who died during the first and the second wave raised in the last days 241 deaths, while nurses were only 56. I don't want to say only is a big number, you know, but it's much lower than the doctors, and probably due to the fact that the doctors under-evaluate the problem. Next one, please.
Francesco, 2 more minutes, please.
Yeah, I finished. I have still 2 slides, just to show how this overwork has psychologically impacted the personnel. You know, we increased the number of personnel in the intensive care, and we deliver an interview to this a questionnaire to these guys. We had a good amount of responses, and 95 of all the people who work, healthcare workers who work with us, 33% males, and 10% have changed their family habits during the pandemic. And you saw that the depression, a moderate and severe depression, came up to 12% of people, and the anxiety inventory for following the indication of bad were high level in 12%, and the worst level anyway in 88%. And also the PTSD inventory was moderate or severe in quite half of the people. And this was especially in healthcare workers who change their family habits. Next, please. Next, please. And also the massless burnout inventory means the quantity of burnout of these people were had a large impact in their personality. And you see, even if the results are not so high, but anyway, this pandemic, especially for people who did not have any precedent exposition, it was very high. So the next, please. This is the last slide. Just to tell you that we made a comparison between the first and the second wave, and what we noticed at the most important point is the healthcare workers in attitude to work and to be determined to give their help is much lower. There is a lot of fatigue and tiredness in the staff, and we are very threatened by the possibility to have a third wave that they should have very badly. Thank you very much for your attention, and I'm very sorry to be so running for the 10 minutes, but I have to have given you some information about our activity. Bye-bye.
Francesco, thank you very, very much for a very insightful presentation. What I hear, and I think that 2 main things I heard is, one, about the change of paradigm from normal treatment paradigms to disaster treatment paradigms. And I think that this is a very difficult thing. The other thing is that for the first time, clinical care and public health are mixed. And at the beginning of the pandemic, we were joking that this pandemic is payback time for all the professors of public health that no one listened to them in class, and suddenly they became the most important people. And I think that we all learned quite a bit about public health, and public health are also learning about clinical care of their patients. And this is really interesting for the future. So let's move to our colleagues from Brussels. Sophie, please.
Hello, everyone. Thank you, Chaim, for organizing this very interesting webinar. So I'm an emergency physician working in a university hospital in Brussels. And unfortunately, my content has already been covered by all of the rest of the speakers, but I'll try and give you our experience from an ED point of view. Next slide, please. Our university hospital is situated on the Brussels Health Campus together with a medical school and a nursing school. We're obviously a university teaching hospital with around 720 beds, with also a separated children's hospital. Our ED has about 80,000 visits a year. We are a level 1 trauma center, and we also have a children's hospital. We are a part of the Brussels EMS system, so we have 2 fast cars in our garage that we can send out. We have an ICU with a capacity of 30 beds, including our pediatrics department. And our OR has 20 rooms and 20 positions in the post-anesthesia care. We are a reference center for diabetes, oncology, fertility, and cardiology. Next one, please. So I would like to give you some numbers. So the blue bars are the total amount of patients presenting themselves in our ED, and the orange line actually are the patients that presented themselves with a suspicion of COVID. This is not the same scale, so the scale on the left and the scale on the right is not the same. But as you can see, starting from the first lockdown until the present day, our total amount of patients dropped spectacularly. We have sometimes days right now from only 100 visits a day, where we normally have 220 visits a day. And this continues throughout the first wave and the second wave. As you can also see, is that in the first wave, the number of patients who were suspected to have COVID was a lot higher than in the second wave. Next one, please. In this slide, you actually can see the proportion of patients who were suspected of having COVID, the gray bars. And in red, you can see the patients who actually tested positive for COVID. So in the first wave, again, a lot more patients suspected to have COVID, and only a few numbers, I say only a few numbers, tested positively. And if you compare it with the second wave, you see that the suspected patients are much less than in the first wave, but the proportion of positive patients is much higher. Next, please. And so if you ask us from an ED point of view what the main challenges were about HR management, and I can say that it was planning, training, and well-being. Next, please. So for the planning, I think that the first major problem was actually sorry, can you still hear me? Yeah, was the reallocation of personnel. So we had a lot of staff available in the hospital because our government during the first wave forced all hospitals to stop all ambulatory care. So we had a lot of doctors in the hospital who were available to be reallocated to the ED, to COVID wards, to the ICU and the newly created ICU. But unfortunately, the coordination of this reallocation was not done centrally. So we had a lot of initiatives who were not aligned and who created often some confusion. And I have to say that the lessons learned made it that the coordination during the second wave was a lot better. For example, in the ED, we had a lot of residents from internal medicine and from surgery who came and help us at the emergency department. But for the consultants, so me, for example, there was absolutely no backup plan. So fortunately, all of our team of consultants in the ED, we remained healthy, so we didn't need any help. But it would have been a real big problem if we would have fallen sick or something. A second challenge in the planning was the new puzzle that we had to make, and that's the creation of new shifts. So in the ED, our main focus was to create a system where the work-life balance was the best possible for everyone. So we implemented shifts of only 8 hours, which made that every 8 hours we needed to switch personnel. And one of the downsides of that is that you need extensive daily briefings. that are very time consuming and often need to be multidisciplinary. And what we actually saw is that we needed them not 3 times a day, but sometimes 4 times a day, also because the organization was changing daily, the treatment was changing daily, the diagnostics were changing daily. So every day we had to tell another story, unfortunately. Next, please. So another problem within planning that is that we faced a sudden need for staff because we divided our department into a COVID zone and a non-COVID zone. It was actually really separated, and we also wanted to separate our personnel. It means if you were working in COVID zone, no way that you could go and help in the non-COVID zones and vice versa. This means that you actually need a double amount of personnel to man your different zones. So we needed extra doctors, we needed extra nurses, we needed buddies to support our nurses. We needed extra logistics because, for example, medication charts need to be doubled. We needed more cleaning personnel because they would stay in the COVID zone, but also our non-COVID zone needed cleaning, etc. And last but not least, I want to say that for the planning, actually during the second wave, it was a lot more difficult. The reason why is because our government during the second wave didn't decide to stop all ambulatory care. So we had to man the ORs, we had to man the consultations, etc., and combine it with the rise of COVID patients. And so there was no staff available to be reallocated to the services who needed it the most. And what we also saw I think it's more for the complete hospital, it's an increased sick leave. I think that in the ED, I think that we were lucky. I think that in the second and first waves together combined, I think we had a maximum of 15 people who got COVID. So we were really spared, I think, fortunately. Next, please. One of the next challenges, Professor Della Corte already told you in detail, but also we were faced with the sudden need in training because a lot of staff in the hospital was reallocated to another department or another service. And we also applied the principles of just-in-time training. And it was the responsibility of the accepting department, I will call it, to organize the different training modules. To give you an example, in our department, we had one of the topics was COVID for Dummies. And I don't mean this in a bad way. It was just really the basics about what is COVID and what to do and which diagnostics, etc. And there was also a lot to do, not only for the one allocated to our service, but also our own personnel about correct use of PPE. I can remember that at the beginning of the first wave that everybody was screaming and yelling that they wanted to wear an FFP3 at all times. Only problem was 0 FFP3s in Belgium, but they wanted FFP3s. So it was a constant war of demands for PPE that we didn't have. So it was really educating all people throughout the whole hospital in correct use and in the appropriate use of PPE. But also topics like airway management and ventilation management with the focus on protective lung ventilations were covered. And then during the second wave, we also focused on prone positioning of the patient and specific nursing aspects because we were told that we should prepare for a tsunami of patients and that our ICU surge would be maxed. So we were preparing an ICU area within our ED. I have some pictures in the next slide, please. So as you can see in here, it seems funny to practice the prone positioning of a patient, but it made us realize that training is absolutely necessary if you're not trained in doing this, because there are a lot of dangers in prone positioning. But it was fun, I have to say. Next, please. So, and last but not least, I would say, I think that it was already covered also, but we immediately understood that well-being would be an important topic throughout this pandemic. And I think in the first wave, somebody already told it, it was solidarity, there was a lot of energy, and it was the all for one and one for all principle. During the second wave, we're much less enthusiastic about this pandemic. It's much more difficult, there is more fatigue. week. And so from the beginning, actually, we started with the creation of a resting area where food and beverages were available, where, if possible, we granted some off-clinic time, and even if vacation was possible, we gave some vacation days to our personnel. Staff safety was a major priority. We had to, in the first wave, the main problem in our hospital were logistics. So the enough PPE and certified PPE were a major problem. And so I can remember that our chief of department, who is unfortunately not speaking today, but I am, he bought the complete stock of a local car dealer of overalls, just to make sure that we had enough PPE to protect ourselves during our jobs. And then last, I would like to say that our hospital also provided supports in housekeeping for staff working in the hospital, and even heartwarming action of our medical students and students of our universities that they offered to babysit at home because our government unfortunately also closed all schools. So our personnel had an option to, that somebody could take care of the kids. This is it. I don't have anything more to add. Thank you for your attention.
Thank you so much, Sophie. I see that many challenges are common and that we are overcoming. It looks like in a very similar way. Hopefully we will not have to use those on the third wave. I would apologize that we're running a little bit late, so if it's okay with you, we will stay. And we have 2 more presentations, so we'll be like 5 to 10 minutes late finishing this work with webinar. I think it's worth it. So thank you for your patience, and I would ask Madalena, please.
Hello, everyone, again. I will try to make it very short and present you the situation in Romania. So I will try to keep it in the 10 minutes time that I have. On the 26th of February, the first case of COVID was confirmed in Romania. And although the patient 0 was identified early on, other cases soon followed. And by March 14th, Romania exceeded already 100 confirmed cases, and most of them being Romanian citizens who were returning from highly affected areas. And thus, shortly after, local transmission surpassed the importation of cases. In response to this increasing number of infections, a state of emergency was declared on the 16th of March, whereby certain rights such as freedom of movement were limited and non-essential businesses were closed. On the 26th of March, the total number of confirmed cases exceeded 1,000, and there was serious concern that the healthcare system would be overwhelmed if the infection rate continued to increase, which was later on confirmed. As an early response, all Romanian nationals who were returning from regions affected by COVID-19 were required to sign a declaration of compliance to a 40-day period of self-isolation. And because many citizens did not report truthfully about where they were returning from, and by the time they were diagnosed with COVID, they have already been infected, had infected at least 30 other people, a lot of medical staff was also infected. Next slide, please. You can see here an evolution of confirmed cases among medical staff. And this is the percentage of total number of COVID-19 confirmed medical staff out of the total number of confirmed cases in Romania. So in the beginning, it is very obvious in the graphics that in the beginning, when people didn't exactly know what medical staff didn't exactly use the PPE correctly, or it was a lack of protocols. The number of cases was very high. For example, in May, out of a total of 15,000 cases in Romania, almost 2,500 cases were medical staff. So this is a very high number, almost 50% of the confirmed cases. Next slide, please. This is also an evolution of cases on 24 hours. So this is exactly, it basically says the same thing as the other one, but it's done on 24 hours period. As you can see in the beginning of the pandemic, also the number of cases was really high among medical staff. Next slide, please. As you probably already know, in Romania, the majority of medical services are provided through the public healthcare system. This system largely relies on all the infrastructure built under the former communist regime. So the Romanian healthcare system faces the problem of understaffing due to the continuous immigration of medical personnel. Consequently, many rural areas have no proximal access to healthcare units, with the closest medical facilities often being located at considerable distances. And by the end of March 2020, an increasing number of Romanian hospitals were already treating COVID-19 patients. In the beginning, it was separated. Only certain hospitals were treating COVID-19 patients. And afterwards, there were separate wards inside every hospital that treated. As infections started to be reported among medical personnel, many wards were closed and patients with other conditions were either transferred within the same hospital or to other medical facilities. As I said before, improper management of the hospitals combined with a lack of protocols and inadequate use of protective equipment resulted in an explosion of COVID-19 cases among health workers. Also, we had concerns about the supplies of protective equipment and the availability of medical resources. As medical staff continued to get infected, Romanian medical system was highly affected by this situation. And although there were sufficient provisions of equipment and new orders were on the way, there were doctors and nurses across the country who presented their formal resignation out of fear of getting infected or infecting their families. Also, some of them got some prescriptions from the family doctors saying that they were unavailable during COVID. So they couldn't be used. Others, even if they did not resignate, they found certain methods of avoiding or evading medical activities in the COVID-19 areas, and mostly of them invoking medical affections. Next slide, please. Okay, so the measures taken by the Romanian authorities were intended to facilitate the hiring of medical personnel. Through the government order, it was given the possibility to hire medical and auxiliary staff without competition for a period of 6 months, or afterwards at the end of the state of alert. Also, the acquisitions of medicine and equipment and the increase of the healthcare budget was voted through this ordinance. Also, medical and support staff were redistributed in all units in urgent need to cope with a large number of patients. And the authorities made an attempt to motivate the medical staff, mostly financially, to prevent the wave of resignations for both employees and deployed personnel. Resident doctors from certain specialties were detached from residency centers in deficient health units to help the doctors. And also to support the medical personnel, a volunteer program was created for medical students to participate in the patient care process. Also, Phone and online consultations were permitted, and the doctors were allowed to issue prescriptions without use of the personal card of the patient. We understood that even if the system itself will not collapse, the overworked medical workers will be brought down by fatigue and sickness, and wards and hospitals will be non-functional in this way. Next slide, please. So this is the situation where you can see that the most trusted components of the Romanian healthcare system during the coronavirus was the medical staff. This is a survey made by Statista website, Statista 2020. And it took into account the answers of 1,010 respondents. Next slide, please. So, in the context of the pandemic, physical fatigue is added to the mental stress associated with a possible infection, prolonged wearing of personal protective equipment, excessive heat provided by them, lack of hydration, alimentation, sleep deprivation, all together accentuate fatigue and the burnout syndrome. This is what we understood from the situation with our medical staff. A further stress factor is the increased risk of infection for the families of healthcare professionals, and having to balance their own safety with the needs of patients, family, and employers can lead to distressing ethical dilemmas. Also, the pandemic has led to numerous cases of depression and anxiety, as well as worsening pre-existing mental illnesses. We also noticed that the most affected medical personnel are from the emergency care units, radiology, intensive care units, and ambulance services. And we also had a problem with the press in Romania, because the way the management of COVID-19 cases in hospitals was communicated in the public space put under a maximum pressure the work of medical staff. In what sense? There were a lot of fake news that appeared, a lot of fake news sites that had to be closed down by the government. And all these news were intended to make people believe that COVID-19 is actually a joke, and that the doctors are only trying to make money from them because they declare patients as dead from COVID after they take money, and things like that. So this was a main issue in Romania, and the doctors were pretty much the subject of all this fake news. And on top of that, a few doctors and nurses have also been the subject of unfair treatment and bullying across the country by neighbors or landlords. Some of them were evacuated from their buildings by landlords and things like that. And we also understood that healthcare managers should be aware of the potential of COVID-19 outbreak and to elevate the risk of psychological distress of medical personnel, and so to provide psychological interventions in this case. So we also understood that support hospitals, modular units can all be opened if the situation demands, but this is not the solution, because healthcare system were not designed to cope with the pandemic of disastrous proportions. And so we understood that people have to be more careful and to understand the risks and be more responsible and try harder not to get infected. So this is it from Romania.
Madalena, thank you so much, and thank you for taking the time out of your job at the National Coordination Center to be with us. I hear the issue of healthcare providers being at the center of fake news and being harassed. I think that this is something very worried that we will have to take into consideration.
It was in Romania, it was a subject that was really worrying.
I think that this is very worrying, and it is my utmost pleasure to invite the last speaker of today, a great friend, Murvin Chan, to present a very unique perception, and it is the response of volunteer organization during COVID. Murvin, please go ahead.
Thank you, Raim. Thank you for having me. Colleagues, thank you for sharing and also for your attention. My name is Murvin Chan. I'm the head of the National Department here in the Netherlands. And I would like to share our experience struggles with special attention to the HR component. This is also the first time we, next to our volunteers, we also have paid staff now, employed staff to do some of the medical interventions to guarantee the continuity of operations. So, for example, medical students or doctors from event doctors we are now hiring for the Red Cross. Barbara mentioned that the first wave everybody wanted to help. In the second wave, this is different. We also have the same experience. And I also heard about the reserve unit of health workers, which we also are thinking about. The next slide, please, Geem. Yeah, some statistics. We started responding 12 March 2020 with the COVID response. It was immediately declared a national disaster for the Red Cross and also for the Netherlands. We raised in total $31 million to fund our operations. And on the next slide, please, we have an overview of the programs we have. We have 6 programs, but the 3 programs I mentioned are the most active ones. First and foremost, of course, medical. So we have healthcare institutions. We are helping trauma center hospitals. 91 hospitals we're currently helping. We also do support with call center to give answers and questions to the people, to the public who are calling the government. So the government cannot, of course, support all these phone calls. So they call the aid of the Netherlands Red Cross. So also transport of non-urgent transport. So we help the ambulance services with non-urgent medical transport, and we transport about 2,000 people. So we look this initiative from Magenta de Viradom, who also have paid and unpaid staff. So we kind of usually have the same system now in place, and gratefully learned from you, Chaim, and the Israeli colleagues on how to do that. Also, I think that, such as every country, we do the testing and the home isolation and the contact tracing, which we support with, as well as paid staff as unpaid staff. We did it in the first ways with unpaid staff, but now when you see that the people are starting to pick up their lives, we need to guarantee contingency of the operation. So we do that with paid staff. And also now with the vaccination coming, we are in agreement with the Ministry of Health to do the large-scale vaccination with our Red Cross volunteers. So the other 2, I don't think that's very interesting for this platform. The next slide, please. So our focus, the upcoming 6 months on the medical support, mainly the tier 1 to tier 2 hospitals, trauma center hospitals, to do additional support, and we do that with the volunteers and paid staff, so that the doctors and the nurses can just focus on their task, and all the general tasks are being handled by the Red Cross. This we also did it in the first wave. We contacted Chaim and Magenta Viradom for additional ideas and support, because our Ministry of Health gave us a special assignment. They were very concerned with ICU beds and personnel. An assignment was given to the Ministry of Defense, the 11 trauma centers, and the Red Cross to come out with an out-of-box plan that does not include personnel already in play. So a new plan had to be divided, and this plan is now being presented by the hospitals. So again, the doctors and the nurses can do their job, so the general task can be done by the Red Cross. And this also is relevant for the ambulance services. So we do the non-medical transport, so they can focus on the urgent care. Next slide, please. So we have 6-7 programs now in place, because we have to make some priorities, but our main focus is on medical support, psychological support, and shelter. And now with the upcoming winter season, shelter is very important mainly for the homeless people. So the Red Cross, in combination with the local government, opens some shelter places where the homeless people can spend the night, get a hot meal with the separation rules in place. Next slide, please. So our organization, in brief, one domestic department, 23 districts, 202 local branches, and 1 headquarters. So these 23 districts, they are responsible for running the operation. We do this with 12,000 volunteers, and we have 80,000 ready-to-helpers. Ready-to-helpers are people just wanted to help. We send them a text message via the phone. Can you help tomorrow? Can you help today? These are 80,000 people. The 12,000 volunteers are more the diehard Red Cross volunteers. And now also the third branch, which is very unique in our Red Cross society, is that we now have employed staff in position, around 2,000 people who do also the medical support, so we can guarantee the operation. And the Netherlands Red Cross has collaborations with several organizations such as the Ministry of Health, hospitals, and shelter. And we don't have many real disasters in the Netherlands, so therefore we don't have many experience. And now the Red Cross has the opportunity to show her expertise, national and international. So we have been asked on many tables to share ideas about policy and implementation, which we are very grateful for. So the next slide, please. I have 2 more slides, so bear with me, please. Addressing the needs is our main focus for the upcoming months. We would like to identify the basic needs among the population, who are the most vulnerable in our in our society. Again, also with the vaccination, the Red Cross is at the table of the Minister of Health to represent the people who are not in the front rows to get a vaccination. So you can think about the people who don't speak the language or who don't have an active status, so they are basically illegal in the Netherlands. The Red Cross also wants them to have the right vaccinations and information. So the Red Cross is at the table, at the policy table, to accomplish this goal. And to do this, we need to incorporate a system where we can positively scan for these groups. So our local branches have a huge role in this matter. Next slide, please. 2 more slides. Now our main goals, as I had mentioned before, preventing the further spread of COVID-19. So every activity we do with the government focuses on these 3 goals, and mainly on the 3 programs I just mentioned: medical, food, and shelter. So the next slide, please. About 2 slides for our HR and crisis management. So we have been working in a crisis mode since 12 March, such as everybody, I think, in this webinar. And the teams at headquarters and the local branches work in shifts and rosters. So we have hugely expanded our capacity to run this operation. And as the demand is higher, we also prioritize our activities and recruit additional people. So our standard operations has been dormant, and we have been focusing 100% on this operation. But even then, we have shorts of hands. So my last slide, next slide, please, is the growth and personnel. We went from the disaster departments, which I'm running, from 28 to now 45. And even then we are still hiring people because it's not enough. So I expect to grow in January to around 150, including the vaccination operation. And our normal national operations numbers are 200 people, and we expect them to grow to 300 people. So this is a huge step upwards in personnel terms. And the last thing I want to say is that we have not only new volunteers, but new volunteers are mainly young people who say during the first wave, we want to actively help. And these are not the volunteers we usually reach, but we now want to hang on to these volunteers because they are very active in the society, and we want to bind them to our organization. This is 1. And 2 is the paid construction employed staff. This has shifted our thinking in the Red Cross, because we are a normal or voluntary organization, but now our governing board and our directors see the light, is, if I may, that with volunteers alone it's not enough, because you cannot guarantee the operation. You have to put in place paid employed systems in place to guarantee your operation. This is my last slide. Thank you, Chaim. Thank you, colleagues, for your attention.
We are all talking about the idea that crises are an opportunity. And I think that Murvin's presentation is giving me a reason for a lot of hope personally, how an organization is shifting from the old traditional roles to very new activities, bringing new people to the table, involving them and showing how an organization-based volunteer can be a real added value to the system, which I think is a highly valuable lesson learned, at least from my side. I would thank you all for your patience and for your wonderful contributions. Sorry, Paloma, I stole your picture. I thought it was wonderful. And I would like just to finish from all of us at the No Fear family, wishing you best season's greetings, peace, good health, and prosperity. Please stay safe, take good care of yourself, of your team, and of yours. We will all, I would like to use this opportunity to promote our last webinar of Work Package 4, which is on crisis communication in the healthcare sector, that will happen next Friday. We have a wonderful list of speakers there, understanding also from this webinar that it is a great challenge to have an effective risk communication, not with the general public, but with our own. So please join us on that webinar. Thank you very much. Stay safe and goodbye.
Thank you. Thank you.
Bye.
Bye-bye.
Thank you. Goodbye.
Thank you.
Happy holidays.
Thank you.
We will say safe holidays on our next webinar.